think we can good to go, right?
Yes, sir. I give you count after.
Yeah.
Yeah, Rishikesh.
Yeah. So we are starting in 3, 2, 1. Please start, sir. We are.
Yeah,
Good
very good
evening.
evening.
Very good evening, everyone. Good evening,
Uh,
sir.
s- so welcome you all to this scientific session sponsored by Bayer. We will be discussing some of the India's renowned ophthalmologists, and they will be sharing their experiences in their uh, use of anti-VEGF and especially aflibercept in different medical retina conditions. So we will be having three speakers today. So first, Dr. S.S. Paul, then followed by Dr. Shumendu Bodal, and followed by Dr. Rachita Sarangi. So should
Yeah.
we follow the serial?
No, so sir, just for information, Dr. Boral sir is starting as a fast speaker.
Okay. So we will be starting with Dr. Shumendu Bodal. Dr. Shumendu Bodal, sir, needs no introduction. He is senior vitretina consultant in Disha Eye Hospital, and he has many national and international awards in his name, of which most important is he has awarded for the best video award in Euretina 2009 and 2010 consecutively, and he has received senior honor award and from American Academy of Ophthalmologists and So, and he has also received the most prestigious Red Buckler Award for Best Video in the ASRS Boston. And so he will be speaking about evaluating anti-VEGF drugs, molecular characteristics, and their impact on treatment successes. Over to you, sir.
Thank you, Shomamo, for nice introduction. So, my slides are visible.
Yes,
sir. Yes, sir. This is
So, evaluating anti-VEGF drugs, molecular characteristics, and their impact on treatment success. So, I don't. So, this is the disclaimer. So, activation of VEGF receptor 1 and 2 by VEGF and prostaglandin-derived growth factor promotes angiogenesis and neovascularization. Whenever there is any kind of hypoxia, like because of impaired vascular function and impaired retinal blood flow, because of diabetes or arteriosclerosis, that can release VEGF, vascular endothelial growth factor, which binds with the VEGF1 receptor and VEGF2 receptor in the vascular endothelium, which can cause neovascularization, as well as it releases prostaglandin-derived growth factor, which releases inflammatory cytokines. So both of which can finally cause the leakage as well as the edema formation in the vessels retina. So aflibercept, it actually targets VEGF, the master regulator of the disease pathology, and additionally targets the key ligand posterior inverted growth factor. So VEGF1 present in domain 1 or VEGF2 receptor is present in domain 3, which both of which can cause like decrease in inflammation, decrease in neovascularization, retinal vascular leakage, as well as decrease in edema. So the aflibercept not only targets the VEGF receptor and the prostaglandin-derived growth factor, inverted growth factor, it also targets the VEGF galactine, that is VEGF A, VEGF B, anti-VEGF receptor antagonists, as well as prostaglandin-inverted growth factor and galactine. So, if you consider the severe molecular factors determine how a drug interact with the body, it actually depends on the binding affinity, elimination half-life, potency, clinical targets, as well as the molar dose. So now first coming to the binding affinity, which determines how strongly a drug can interact with its targets. Like if you compare with the available drugs like faricimab, ranibizumab, romlusumab, and aflibercept, for faricimab, it is reported to be comparable to the ranibizumab, that is anti-VEGF A arm. But for the other three drugs, you can compare the aflibercept as the binding affinity is like actually minimum inhibited concentration is also lowest and binding affinity is maximum. So it's statistically higher VEGF binding affinity than the other two drugs like ranibizumab and brodalumab. Now coming to the potency. So potency for faricimab is not available, but other three drugs it is available, and it is seen that potency is actually very minimal. That means that minimum inhibitory concentration, it is very minimum concentration is required to inhibit the VEGF-A 165 term. So lower inhibitory concentration 50 value, that means the increased potency, that means the drug is more potent. It is several times more potent than the available drugs like ranibizumab and brodalumab. Now coming to the half-life, which provides an half-life provides an insight into the drug concentration in the body over the period of time. So from the multiple studies, it has been seen that 11-meter half-life for human half-life it is available, and for the aflibercept is 9.1 to 11 days. For faricimab it is 7.5 days, ranibizumab 7.2 days, and for brodalumab variable for 4.3 to 5.1. Now, coming to the binding target determines the downstream effect of a drug on disease pathology. Like if we are considering the single target, that is brodalumab and ranibizumab are there. For the dual target, it is faricimab are available, VEGF-A and ANG2. And for multiple targets, not only VEGF-A, also the VEGF-2B and prostaglandin inhibitory growth factor and galectin. So, aflibercept significantly decreased the intraocular VEGF and prostaglandin PIGF level from baseline to months 2 in patients with DME. And actually, why PGF is important for the target molecule? Actually, it is whenever there is elevated PIGF, it can activate the VEGF receptor. And so you can see in patients of DME, VEGF level are 61 times higher, and postgrandian inhibitory growth factor level is 119 times higher. So VEGF concentration in DME actually, if you inject the inhibitory effect is, if you can see, from 192 to 3.2 in month 1 and 3.9 to month 2 for VEGF concentration, and postgrandian inhibitory growth significantly decreases from 4.4 to 0.6 in months 1 and practically 0 in months 2. So to targeting additional pathway beyond the VEGF pathway further improve the efficacy outcome. So it has been seen that VEGF-A and prostaglandin inhibitory growth factor, if both of them, they are responsible for vascular permeability, inflammation, neovascularization, edema formation, and vessel stabilization. But ANG1 and 2, they are equally responsible, but they are actually the cell loss, endothelial cell loss, perivascular cell loss, so that can increase the leakage and also the ERM formation, so it can decrease the other factors. But it has been seen that the ANG2 and pathway is the relevant target for the treatment of exudative retinal diseases like DME and other diseases, you can say Coats disease also. And the during angiogenesis, ANG2 is upregulated and competitively binds with the TIE2. So it has been seen that higher VEGF states ANG2 antagonistic activity may promote destabilization of the blood vessels. So the studies has been seen that from the individual study, you can see the kinetic binding and PM value. You can see the faricimab TIE2 receptor and NESVAPO, which is a very strong anti-ANG2 than the other agents. So faricimab is actually dual target. It is inhibiting the VEGF-A and NESVAPO. But Ruby Onyx study, they're actually both ANG2 and VEGF receptor pathway, which didn't provide any additional improvements in vision. It's kind of contradictory statement what we have seen in faricimab and other studies, that nesvapimab, although it is a very potent ANG2 inhibitor, and aflibercept, which is a very potent VEGF-A to B, as well as the prostaglandin inhibitory growth factor inhibitor. So these study also that they showed no additional functional benefit with potent ANG2 inhibition in combination with aflibercept. So there is unbalanced study design favoring the faricimab, and the additional ANG2 targeting with faricimab didn't confer any additional clinical benefit about the aflibercept. So this is another study, is Avenues clinical study, where it has been shown that ranibizumab and faricimab achieved similar level of plasma and STU inhibition after one injection. So aflibercept showed the most durable and robust suppression of VEGF and STU versus bolocimab and ranibizumab. So aflibercept actually delivers the comprehensive and highly durable targeting where it matters. If you compare the aflibercept, bolocimab, ranibizumab, and faricimab, you can see the binding affinity PM value estimated in it is 0.172 for aflibercept, and is much higher in cases of other three drugs. Estimated half-life, human half-life is 9.1, but for the others it is less. Molar dose is 1, and it is for the higher, they are also higher, but maximum is with bolocimab. So each drug has the different characteristics. You have to choose it accordingly in your like practical situation, like where you are dealing with the CNVM or PCB, or you can you are dealing with this DME cases. So number of target potency, inhibited concentration is also concentration is 2.42, and for bolocimab is 5.74, and for ranibizumab it is 10.82, and so this is actually inhibited concentration is very minimal for the aflibercept compared to the other two drugs. So additional pathway for the aflibercept plus nesvatinib, you can deal with the multiple factors like VEGF-A, B, prostaglandin inhibitor growth factor, galectin-1, as well as the ANG2. For the faricimab, it is VEGF-A and ANG2. So guidelines for what could be the guidelines for the DME cases, whether it is non-central involving or the central involving, the vision. So you cannot avoid the age-old mode of treatment, that is laser treatment. Focal laser, it has been shown to be an effective treatment option in the management of DME in the early pioneering studies compared to the sham treatment, but currently the era of anti-VEGF injection clearly not the standard of care anymore. But in the practical situation, we are also facing the same problem in presence of edema, laser, focal laser, better to avoid, but in absence of edema, but it was there. So after giving anti-VEGF or the focal laser has some value to prevent the recurrence. So RCT-like outcomes are possible with aflibercept in clinical practices like in neovascular AMD, PCB, and DME. You can see the in neovascular AMD, vision gains maintained through year 4 with a proactive treat and extend dosing regimen. PCB, it is also vision gain. In Morimoto study also showed that the vision gains maintained through year 2 with a proactive treatment and extend design doses regimen. And for DME, by Woodfield study, it has been seen that vision gains achieved with a meaningful reduction in the treatment burden after early intensive dosing pattern. So now coming to the clinical, like a practical real world situation where it's a case of 86 years old male with recurrent CNVM, both eye, and in the right eye is still stable, and the left eye you can see there is recurrence of edema, and after giving first injection of aflibercept, the edema has gone down significantly. The both eye interretinal cystoid changes has totally resolved, and after second 2 months, there is again recurrence of edema, where I advise for this injection. So and this the patient didn't take it. After 18 months, he appeared in my OPD, and I did this OCT angiography. What is the pattern? You can see the edema is still there, but OCT angiography was showing that it is the open loop configuration of the CNVM. So this is quite regression is not that much active, but still you have to treat this patient. So these are all atypical cases. I'm telling you, this patient will turn up for the third dose, and you know all the common diseases can be treated by very like huge PEDs can be treated like very valuable with this drug. So it is coming to the second case, 78 years old man, one-eyed PCV cases, where one-eyed PCV is a very tricky situation where you have to choose the drug accordingly because many times treating one-eyed this kind of PCV patient after giving anti-VEGF patient, the disease can rebound very badly with massive submacular hemorrhage even after giving some anti-VEGF injection. So this is the case where you have seen the PED is there, and there is a large RPD because of the multiple dose of anti-VEGF, and you can see the RPD in the OCT, and where patient came with the recurrence of edema. Right? Patient was quite follow up nicely, but whenever there's such a huge alarming edema, so I have given the first dose, and after the first dose, the edema is totally just gone. The large C section is almost going to rupture this ILM band. You can see the edema is totally gone. So again, there is recurrence of edema after 2 months, and where I have given the second injection, you can see the edema is vanished. So coming to the like patient reappeared with this edema where I have given the third injection. You can see the edema is still it's totally vanished. Now patient has there is recurrence of CME, and where I have given the fourth injection, and patient responded nicely. So these kind of situations are with recurrence. It may not follow the actually we are following the loading dose pattern, but here you can see the whenever there is presence of edema, and it is quite maintaining almost 2 months duration, 1.5 months to 2 months. It is little bit duration is little bit more compared to the ranibizumab. I should not say it is 2.5 months like ranibizumab, but it is almost like 6 weeks. That is I want to share. I want to know what are the the experience of the other speakers also. Now coming to the D is another interesting case with DME with bilateral NPD and CSME. The patient has taken bilateral aflibercept. You can see the patterns of CME is quite atypical. And this type of pattern is you cannot say it is spongiform or like this. You can see this mainly it is mainly inner retinal layers, and in the right eye, left eye is also have a center involving DME. After giving the first injection, it's not responded that much. But second injection is not followed, but third injection it works nicely. So in summary, the aflibercept actually targets where it matters, VEGF and prostacyclin inhibitory growth factor, thereby inhibiting the downstream signaling via VEGF receptor 1 and 2, which is the master regulator of pathological angiogenesis. So targeting alternatives to date, both preclinical and clinical data suggests that there is no additional benefit of targeting alternatives to the VEGF receptor signaling pathways, and it's also highly durable. Separate independent studies will suggest that it has a greater affinity to VEGF-A, greater potency, as well as longer half-life than other available anti-VEGF agents. But these factors, they contribute to strong VEGF suppression seen with this aflibercept. Thank you.
So excellent presentation, Dr. Shubhendu Wadal sir. And I think before going to the next speaker, may we discuss some of the points about your presentation. Firstly, you have enlightened us about the theoretical part of aflibercept, why it is superior to other molecules. So my question to you, sir, is we are using aflibercept for a long period of time, and unanimously we will agree that this molecule is very much safe and very much stable, and efficacy wise also it is very efficacious in neovascular AMD and diabetic macular edema and other RVO cases also. But till now we are not very much aware about the this Ang2 pathway. So after the faricimab has came into the market, they claim that their extra blocking effect to the Ang2 pathway, this molecule is getting more durable and more efficacious. but your presentation is little bit different. So what is your if you compare your experience with aflibercept and faricimab, so is this theoretical part reflects in your practical use of this molecule, or do you differ in this case?
It's a very nice question. And the topic is very much controversial, I should say. In the round, these studies, whatever they have discussed with the minimum role of this ants to that pathway. But still, you cannot say that diabetes is a very complex disease. Till now, we have some few aspects of diabetic retinopathy has been highlighted, and from which we are doing all kind of studies. Few drugs are there following that these factors are responsible for diabetic and these factors are not responsible. So these are not important. But still, whatever studies are going on already happened. But see, from that only we can say no factors have absolute value, and no factors have nodal value. Whatever factors are they have discovered, these have some role in the pathogenesis of the DME. So one cannot say that DME, this ANGS2 has no value, and this posterior galectin-1, these factors are much more important. It is actually the real world study which matters. Whatever study they have already done. So these studies are not, they are actually company sponsored study, company driven study, but real world in the patient when we are dealing with, they have multiple factors, like they are systematic disease. So you cannot say this factor is not responsible, this factor is responsible. So for faricimab, obviously we are getting the result, whatever, already studies have happened that ER information is less. That's the ANGS2 is responsible. So vascular stability is there. So these are the factors for faricimab. And for the aflibercept, the Ronings and Ronings study, they have proved that this factor has some minimal value. Every factor has some value. For me, it is every factor has value. You cannot say this factor has no value, but whatever the factors are discovered, all these factors have some value in different situations. Maybe in those situations they don't have value, they didn't have any kind of value. But for our practical aspect, I saw the value. This is for the sake of this presentation, I highlighted this study. But for the practical aspect, real world study, I cannot deny there is no value of this ANGS2. So this is my take.
So because we doctors are end users of the molecule, we are not scientists.
Absolutely.
We don't know what is happening in the molecular level. These are the area where the scientists cover these things. So we have to depends on our clinical experience in patients, whether it is more durable or whether it is more efficacious. So if so after one molecule is coming into the market, so every molecule has its own subset of patients where it is we prefer more. For you, what is the subset of patients in neovascular AMD, and what is the subset of patient in diabetic macular edema patient where aflibercept is the first drug of choice in your clinical practice?
Look, I rarely consider the aflibercept as a first drug of choice for very rare condition situations. Like for me, it is always the standard mode of treatment is ranibizumab.
Okay.
Whenever the Avastin was very popular in the era of 2010 to 2015, in that era, the Avastin was the first line of treatment because of its cost, and it is availability as well as the acceptability of the patient, and it is the clinical effect also. It's giving very good result. If any financial constraint is not there. So I can choose the other drugs. First of all, the safety. Aflibercept is a very safe drug. And if you consider finance is not the cost, not a constraint, you can choose aflibercept. But if you are choosing the second generation drugs first line treatment, if there is recurrence of sometimes some kind of tachyphylaxis develop to this drug, what would be your second line of treatment? So that's why I'm using either ranibizumab or biosimilar drugs. These are like less costly. I have other three second generation drugs in my hand, so I can choose. I am explaining this thing to my patient. You can afford, but still better to start with the standard mode of treatment, that is the ranibizumab.
Okay.
That is my line of treatment, my line of thinking. People may differ with me, but still I think that is the misuse of the second line of treatment, second generation anti-VEGF drugs for me. If you are considering aflibercept or faricimab as a first, today I'm seeing just reading one article, the faricimab as the first line of drug for DME. There's no doubt about it. There are so many advantages. But if the DME is recurring, what will be the second? Can you come back to the ranibizumab again? So the patient will not accept. That is the real world beauty.
Yes.
That is the real beauty of the real world. That is the conflict. What patient can think about you? You are using such a costly drug now. Again, you are using that some biosimilar after 6 months or 1 year. So you are coming to you come to this biosimilar, start with this biosimilar drugs. Now you can shift to that has some meaning. For me, it's very practical. I am not going with any kind of study. It is
Okay.
every drug has some beauty. So aflibercept for me, if it is PCV, very large PED, aflibercept works very wonderfully. So jolly well, you can start as a first line of treatment. Patient came with small submacular hemorrhage, very large mass PED. You can start with the aflibercept, no problem. But for me, little bit of CNBM is there, vision is 612, little bit of edema is there. And start with these other first generation drugs.
So I think there are multiple school of thought. You have your school of thought, and some I have seen some of the senior consultant who have emphasized that hit hard from the very beginning. If you have to control the disease, some of them are prefer to start with higher molecules so that the best of the effect they can deliver to the patient. That's their mode of thought.
Absolutely. But if tachyphylaxis is developed to that higher molecule drug, what you would do? You don't do any much more, only few drugs are available in the market.
Okay.
Only few drugs.
So I think many of the leading institution of India, like LV Prasad Hyderabad, is following your thought only. They start with Avastin in most of the cases in the first line. Then, if it is not working, then they can switch to the ranibizumab and later on switch to the newer drugs.
US also. You can remember the one Netralayam has one sponsored program was there where Dr. Rajanaran was telling. I asked the same question, what is happening in USA? How you are going to? You have patients are totally insured patient, so they don't have any problem with it. But still, insurance company they are not agreeing with if you start with aflibercept or faricimab costlier options. They are not actually allowing all these things. They are allowing the biosimilars or the minimum cost drugs for the first line of treatment. They are not encouraging the use of this faricimab or maybe aflibercept as a first line of treatment. US. So that is also, I think it's very practical.
Okay, so we will be discussing this later also because this is a controversial topic, and as we are discussing about LV Prasad Eye Institute's protocol and this thing, we have Dr. Rachita Sarangi ma'am with us, who is a fellow of LB Prasad Eyes, and I will be taking her opinion also about this after her presentation. So before that, a short introduction. She is currently working as a senior veterinary consultant in Center for Sight, and soon she will be switching to Dr. Agarwal's, if I am not wrong. And she has given talk in many national forums, and she has a major role in during COVID times. She has authored a chapter in Eye in COVID. So we will be very much eager to know her experience in aflibercept. Her topic is a clinical review of aflibercept in treatment of center-involved DME. Over to you, ma'am.
Thank you, Dr. Mandal. Good evening, everyone. Share my screen.
First, make it click on allow.
Is it visible now?
Central. Yeah, it is visible, but you click on the central box allow.
Sure.
Yeah, it's visible.
Yes.
Make it full screen.
Sure.
Yeah.
I'll start the slideshow.
Yeah, it's visible.
It's visible now.
Yeah,
Thank you. So, good evening, everyone. I would like to talk about the emerging treatment patterns in diabetic macular edema. I'd like to thank Bayer for giving me this opportunity. So, I think all of us as retinal physicians, we know that this persistent diabetic macular edema or the chronic persistent diabetic macular edema is like the most difficult part of our daily OPD and daily patients that we see, because these patients keep coming back and we have to keep wondering what to do next. So chronic persistent DME was said that the prevalence was around 40% of eyes receiving ranibizumab injection for 2 years. And the quoted study found that this subset had visual outcomes only slightly worse than 60% in whom the DME did not persist. We've seen patients where we treat, the DME goes away, vision is good, and remains stable till the systemic control is good. But then we see another subset where no matter how much we treat, what drug we use, the DME persists, and these have poorer visual acuity. So how do we tackle these patients? Persistent DME was more likely with bevacizumab than with aflibercept or ranibizumab. It was shown by a post-hoc analysis of protocol T in DRCR-NET. Going to my patients, my limited experience compared to all the other people on the panel, Dr. Boral sir. This is my first case. I will just show you over the years how my practice has probably shifted a little from maybe using only ranibizumab to including aflibercept in some difficult cases. So first case is a 62-year-old female patient, known diabetic, poor control. HbA1c was around 9%. She came with diminution of vision in the left eye since 6 months. That was her OCT when she came. You can see the hard exudates, the intraretinal fluid, and right eye was okay. Left eye was counting fingers 5 meters because she had a cataract also. She had moderate NPDR and cataract more in the left eye with central involving diabetic macular edema in the left eye. So that time we planned to go ahead with cataract with intravitreal triamcinolone injection. Initially, I used to generally, when we had a case where we had to combine cataract surgery with the diabetic macular edema treatment, I would prefer a steroid initially because that would take care of the inflammatory component also. So I went ahead with that. Left eye vision improved remarkably to 6/9, and I sent her back to the physician for better metabolic control, worsening of the edema on the OCT also. And this is something that I have also noticed, not probably in every case, but more commonly wherever we use steroid, that with IVTA we see a rebound in 1 or 2 months, and with Ozurdex we see a rebound in around 3 to 4 months. Not in all cases, but yes, in some. And then I, at this point, decided to go ahead with an intravitreal aflibercept injection in her case. And she was actually lost to follow up. She said her vision was much better, so she didn't come back. This is almost 10 months post the first aflibercept injection that I have given her. Vision in the left eye was 6/9 N8. She was happy with her vision. Saying that just a few days, she has noticed some decrease in her near vision. The hemoglobin HbA1c was better at this point, so I decided to go ahead with one more aflibercept injection. Mind you, I'm giving this second injection after 10 months of the first injection. And again, as you see, she was lost to follow up, came to me almost a year later, saying her vision had been stable, her systemic parameters were better, and though there is on the OCT, you can see some amount of fluid, and since the center was clear, I just thought we will observe because her systemic parameters were okay. You see here again, she's come back to me almost 2 years later with now diminished vision in the right eye, mainly because a cataract had developed and some center involving DME also was present. Left eye, which we had operated before for cataract, was stable. She had 6/9 N6 vision in that eye. This is how the OCT looked. I'm sorry, I think this is not one of the central scans. You can see one of the central scans are the 8th scan, which intraretinal fluid that you can see. Left eye OCT, though it had some intraretinal fluid, since her vision was stable, I didn't want to treat the left eye at the moment immediately. So went ahead with right eye cataract surgery with intravitreal aflibercept injection. Just because the last time when I had given a steroid, she had had a rebound in a month's time, I decided to go ahead, and she had shown good response to aflibercept in her other eye. So with this, her vision improved to 6/9 N6. Left eye was again 6/9 N6 and stable. After 2 months also, the vision and the OCT remained stable. So I have just kept her under observation. I have not seen her after this last visit in 2021, but I hope with her good metabolic control, she is doing good. These patients generally I see post 3 to 4 months or SOS if they notice any worsening in their visual acuity. Coming to the case 2, 65-year-old female patient, known diabetic, very poor control, HbA1c was 11%, had diminution of vision in both eyes since 1 year. She had received multiple Ozurdex injections, and the last one that she had received in both eyes was just 1 month ago. She had just come to me for a second opinion. Her vision was 6/18 N8 in both the eyes. That was how her OCT looked. Since she had received an Ozurdex implant just a month back, I thought we'll wait and watch. I just sent her back to the physician for better control of her systemic parameters. She came back to me after 1.5 years because she was okay in between, but she noticed some diminution of vision in the left eye since 2 months. She had already received some multiple anti-VEGF injections in both the eyes elsewhere before. And again, I generally, every diabetic macular edema patient, I insist to see the systemic parameters when they visit. And her HbA1c was around 8.5, better than before, but her hemoglobin was 9 gram percent at this point of time. So maybe the worsening was related to that. Her right eye was the same, around 6/18 N8. but left eye vision had dropped to 660. There was intraretinal fluid and subretinal fluid component which was there. At this point, I chose to intervene with intravitreal aflibercept injection, which I gave in January 2020 as is seen here. I sent her back to the physician to get iron supplementation for her anemia. After a month, we can see reduction in the subretinal fluid, vision had improved. I went ahead with the second injection again, and with some vision improvement and OCT also showing minimal improvement, I went ahead with the third injection. So I've given 3 almost monthly injections of aflibercept here. And but after these 3, she has been under regular follow-up with me, and her systemic parameters are much better now, and she has not needed an intervention since then. So 3 injections of aflibercept in 2020, and she has been almost coming to me every 6 months since then. Her vision is stable, though OCT always shows some amount of spongy edema like this in her case, but I'm not chasing the OCT since her vision is stable, she's happy, systemic parameters are okay. I am just observing her. These are her next visit. Her last visit to me was 1 month back. I have not included the OCT report here because it was almost the same. Her vision is 618 N8 in N6 in both eyes. She's developed a little bit of ERM, as you can see in both the eyes, but edema is almost stable and vision is stable. So I'm just following her up every 4 to 6 months. This is an interesting case where this 64-year-old male with known diabetic average control had come to me. He was a chartered accountant by profession. Suddenly, he had started noticing difficulty in reading. So he came to me on examination. It was a moderate NPDR with central involving DME in both eyes. Vision being 636 in the right eye and 612 in the left eye. This was the OCT. Now, once I saw the OCT, I suddenly started rethinking my diagnosis because it somehow looked like a fibrovascular PED over there to me. So I didn't know whether I was dealing with a CNVM or a DME here. I actually got an FA-ICG also for this patient. I'm sorry, I don't have those reports, but the reports came out to be in favor of DME only. There was no hotspot on ICG, no active CNVM component. As Dr. Boral rightly mentioned, I think all of our first choice is still ranibizumab. I still go for ranibizumab in cases where I am treating naive patients, unless there is some very complicated component like a lot of SRF or anything where I'm thinking of a higher drug to start with. So in this case, I went ahead with ranibizumab, both eyes around 1 week apart. Though the OCT did show improvement in the PED also, in the intraretinal fluid also, he was not very happy with the vision because it had not cleared up. And patients expect immediate improvement in the vision. So at this time, I discussed the options with him. He agreed for going ahead with aflibercept, and we gave aflibercept in both eyes 1 week apart. After 6 weeks, when he came to me, he was happy with the vision. It had improved to 612 in the right eye and 6.9 N6 near vision in both eyes, which was the most important consideration for him. We see that the PED has almost resolved in the left eye. Intraretinal fluid also has gone. Right eye was slowly resolving. I have given only one anti-VEGF, aflibercept injection, in this case, and followed him up after 15 weeks. The PED had completely resolved in both the eyes, and even the intraretinal fluid has resolved quite well. So he's come down to a 6.9 and 6 vision in both eyes. He's happy. I stressed about good systemic or metabolic control. This is a comparison OCT with only after 1 injection of aflibercept. He has been coming to me for follow-up. He has not required an injection after that. He's keeping his systemic parameters under good control. And I'm just following up once in 6 months. Coming to these two set of cases that I have next, where I said generally my practice was whenever there was cataract with DME, I used to prefer a steroid, but that has sort of changed over the years. I am even giving aflibercept in these cases, and it is showing good response. This is a 66-year-old male. He had moderate NPDR and chronic DME. Again, multiple anti-VEGF injections had been given elsewhere. I had also given, and he was finally stable with 2 intravitreal DEX implants in both eyes in the past 8 months. He had undergone cataract surgery with the DEX implant a year back in the right eye. Vision in the right eye was still 660, and in the left eye was around 618. So this was what his OCT looked like, a little worse in the right eye with some outer retinal changes also, which is why I was thinking that the vision was not improving too much even after a cataract surgery. And I decided to go ahead with an intravitreal aflibercept injection for him because he had this troublesome increase in IOP post his past Ozurdex injections also. So discussed with him, I went in for aflibercept in the right eye. There was actually improvement in vision from 660, it came down to 618 in the right eye, and left eye I had not intervened, but showed an improvement. Every visit I used to keep a check on the IOP also. He was okay. He came back to me, as you can see here, after 4 months. After 4 months with some decrease in his left eye. And as you can see from the OCT, you can see that component of cataract shadowing. So he had developed a cataract in the left eye, and that was what was causing more of the vision loss. Here again, I went ahead with cataract surgery with aflibercept injection this time. And his vision had improved after the surgery to 6.9 and 8 in the left eye. Right eye was remaining stable at 618, so I was just following that up. I have not seen him after this 2024 visit, so I'm hoping he's also stable. This is another case where cataract was significant. Vision in the right eye was 660, 624 in the left eye. I had advised cataract with aflibercept in both the eyes, but he wanted to go ahead at one eye at a time. So we went ahead with cataract with aflibercept in the right eye, and left eye, I said we cannot let the edema go till he plans to do the cataract surgery. So I said at least we'll go ahead with an injection. I went ahead with intravitreal aflibercept injection. Not much of an improvement vision-wise post-op that he noticed, immediate post-op, that is 1 month. But over the time when he came to me after 4 or 5 months, his OCT was better, and vision was also slowly improving. Again, left eye cataract was due, so we went ahead with left eye cataract with aflibercept, where the vision in the left eye then improved to 612. Right eye, we gave another injection, and it was maintaining at 624. He is now stable. He's not received an injection at least for this 1 year. From 2025, Feb 2025 till now. Just a comparison OCT showing how it was before treatment and after treatment. The spongy edema still persists, but his vision is stable and it is not worsening on the OCT, so I'm observing him. Another case where again, cataract, moderate NPDR, and central involving diabetic macular edema. Right eye vision was not too bad, 6.9. Left eye vision was the worser one with 636 parts because left eye had intraretinal and subretinal fluid component. So, and because of financial constraints, he got convinced to go ahead with cataract surgery and aflibercept injection only in the left eye. We still went ahead with cataract with ranibizumab in the right eye. and post which his vision in the right eye had improved to 6.6 and 6, and left eye also had improved to around 6.12. There was still that a large intraretinal cyst that was there, for which I gave another second aflibercept injection. Following which there was improvement in his left eye also. But when he came for a follow-up almost 2-3 months later, he came with a sudden decrease in vision or black spots in the right eye, and we saw that he had developed PDR with a minimal vitreous hemorrhage. So for which and the edema was not too much, so I went ahead with the PRP3 sittings, and left eye did not show any clinically significant new vessels, so I just followed up. We couldn't do FFA because his serum creatinine was a little high, and that was what took him some time to come back for the next visit. Though he was comfortable vision-wise, what I noticed this time was a little increase in the diabetic macular edema. But he was on medication now for his increased serum creatinine, and he didn't want any intervention. I had advised for injection, but he didn't want an intervention. So I just sent him back to the physician to keep his systemic parameters under control and review as and when he was better. And I have seen him recently. He is maintaining stable vision. So I have not injected post that last visit. Generally, as you have seen all these cases, and in a private practice like ours, we cannot really enforce a treat and extend regimen. We follow a PRN regimen only. This is one patient where I have been able to do a treat and extend regimen because he was a CGHS beneficiary. 70-year-old male, both eyes, stable lasered PDR with chronic DME. Right eye was his good eye. He was, whenever the right eye vision would go down, he would come to me. Right eye at this visit was around 6.9 because of some intraretinal fluid, as you can see there. Left eye was aggressively lasered somewhere outside, and so would not improve. Even if there was no DME, would not improve beyond a 624 vision level. So he had received, I have also given him ranibizumab initially, but then he was a little troubled by having to get an injection almost every 1.5 months. So discussed with him and shifted him to the treat and extend regimen of aflibercept. He generally comes once in 3 to 4 months. He says that is when he starts noticing decrease in vision, and we go ahead with an aflibercept injection. With that, we've been able to maintain his vision at 6.6 in the right eye. We still, you see, there is still periods of worsening that happen. That is when his systemic control is probably not good. This patient is under dialysis, so he has his ups and downs. But at least we've been able to maintain good visual acuity. So the take-home message from this my experience that I have presented is diabetes is obviously systemic disease, so has to be controlled in that way, where systemic control is very important. We have to collaborate with the diabetologists or the physicians when we are treating our patient. Chronic persistent macular edema can be followed up and treated PRN or treat and extend the OCT, and always aim for the OCT to be dry. If the vision is stable, we can just keep following up these patients without injecting multiple times. And intravitreal aflibercept injections has shown to achieve this kind of stability in DME and has proven to be durable also, obviously along with good systemic control of diabetes. Thank you.
So wonderful presentation, ma'am. A wonderful collection of cases, because your topic is chronic persistent DME, which is bothering all of us in our day-to-day clinical practice. We are not very much sure that in which clinical setting, which molecule is best for that patient. And over to this is very bad systemic control makes these cases more we cannot manage this patient because of this systemic uncontrolled status.
True.
So my question is, most of the cases we have seen that you are not trying to dry the macula as much as possible. Rather, you are observing these cases where the vision is stable and the edema is stable.
Yeah.
So, is this your take in most of the cases, or if you want to switch to other molecule if it is not drying, what is your treatment plan in cases?
No, Dr. Mandal, this is my take in the cases. That's why I've shown these cases to you. Sometimes in our practice, yes, one risk is when, the patients don't come back for a follow-up. That is where the risk comes when we, sort of want to observe this kind of edema if it is still persisting on the OCT. But I think a good conversation with the patient where you stress the importance of fluid and ask them to be vigilant about their vision and systemic control, they do understand and they do come back. So if a good follow-up is being maintained by the patient, I think we can observe. I've shown you that patient who has been with me from 2021, so 5 years now. I have not injected. She is stable vision wise. Her edema has not worsened on the OCT. It has remained the same. So these patients we can observe. But I
Yeah.
think DME, we can take that liberty. I don't think CNVM we can, because CNVM fluid is generally not this cystic degenerative type. So there maybe we need to, aim at a dry macula.
So, in most of the cases in DME, do you prefer PRN from the very beginning, or do you prefer to load the patient after that you will follow the PRN regimen?
Uh, Dr. Mandal, good question. My take would be to load them, but sometimes you see, in a private practice, patient needs a lot of convincing. Sometimes when they come back for the loading dose and you see that the OCT has no fluid, they do not agree to take that injection.
Yeah.
So we'll have to just probably counsel them that if you have not taken an injection, then you please, come back for a checkup when, it is scheduled. Otherwise, if the fluid keeps on increasing, it may affect the vision irreversibly later. So yes, I mean, as a practice, I think I would want to load or at least do a treat and extend, but in majority of cases, it's not possible. So we generally go by the PRN only.
So, in some of your cases, I have seen that we usually switch from anti-VEGF to Dex implant in resistant cases after tachyphylaxis or something. In some of your cases, you have switched to
From Dex to anti-VEGF.
aflibercept. So, what is the thought process behind this?
As we know, conventional teaching is always that whenever there is a more inflammatory component that you see, and diabetic macular edemas do have a considerable inflammatory component in them. So in those cases, it's always better to use the steroid. And I have been using the steroid. I wouldn't say that just because of these 2-3 cases that I've shifted from steroid back to anti-VEGF, I don't use. I still use the steroid, but yeah, in these particular cases of mine, one thing is I noticed a troublesome rebound in one case. I noticed increase in the IOP, which was happening in another case. So in those cases, I wanted to give them another option, maybe a safer option, and it worked. So it's not like this has happened every time. There has been cases where I've shifted from steroid to anti-VEGF and then gone back to the steroid again because they have not responded very well to the anti-VEGF also.
So, in few of your cases, like case 3 and case 5, these cases, I have seen that there are inflammatory markers. like neurosensory detachment and some hyperreflective foci are there. So in these cases, after using aflibercept also, you have achieved to maintain a gap of 6 months or 10 months
Yes,
injection-free intervals. So do
yes.
you think that, and as Dr. Bodal was discussing about ANG2 component of aflibercept also, so
Correct.
if there is a chance that aflibercept also has some anti-inflammatory effect that is not highlighted properly.
Definitely. Actually, Dr. Burrell's but the first or second slide also mentions how the placental growth factor component has some effect on the inflammatory pathway also. So that, I mean, it's not like an all or none that if there is inflammatory, then only a steroid will work. I think we have, with our experience, learned that if there is an inflammatory component also, anti-VEGFs, even ranibizumab works in some cases with inflammatory component. So uh, it's not all or none. If it is a very marked inflammatory component, then maybe yes, they respond better to a steroid rather than an anti-VEGF.
Okay, so the discussion will be continuing. Let's switch to the last speaker of this session, Dr. S.S. Paul sir, who needs no introduction. He's a senior vitreoretina consultant in Kolkata Netralayam Hospital, and previously he was the deputy director of Shankar Nethralaya, and he has many national and international presentation, and is very much his medical retina as well as surgical retina experiences he usually shares to us, and we follow this. So his talk is about visual outcome in DME, assessing the efficacy of Q16 aflibercept injection. Again, we will be highlighting the durability part of aflibercept. Over to you, sir.
Yeah. Good evening. Thanks, the company, for sharing this all these slides. So now almost around 9:30, and outside is raining like hell. Anytime I can lose my signal. So after these two presentation, if I'll tell that like per year you have to take 11 injection at least, then I think people will definitely beat me. Okay, so somehow I'll just my topic is how reasonably we use this molecule to get maximum benefit for the patient and for yourself. For the patient, that means less follow-up, less cost, and good visual outcome. And for you, patient happiness. Okay, so what? Okay, fine. So, okay. So, as you know that like diabetes is increasing, and what we are getting within next 25 years, we'll get almost around 2 times the number of diabetic patients in our clinic. Okay, so if the diabetic patient are increasing, that also increases the number of visual sight threatening like a diabetic retinopathy, which is almost equally 2 times what is projected for the next 25 years. And as we know that the diabetic eye symptoms are much more common. So what do we feel? Our future is very bright as a retinal surgeon, because we'll get a lot of patients. Okay, though it is not good for the as a human being, but it is good for us, because the disease is we can treat the disease to get maximum benefit. So basically what we want, we want a proper formulation of the treatment protocol so as to get a maximum benefit for a long time. Okay, so these are I'll just share some study which gives the evidence that this is the proper protocol. Okay, so this is these three studies what they're telling. Just a minute. Okay, so basically what they're telling, if you
I think, sir, your
start,
your
Yeah, sir.
moving.
you got it?
No, sir.
It's
Sir,
showing?
your screen is not changing, sir.
So it
Not
has
seeing,
now
Not changing, sir. Not changing. Your screen.
not changing.
Not changing, sir.
Slides are not moving, sir,
Sir,
actually.
you can stop share once and again reshare.
Oh, this is hanged there. Okay, now it is moving.
No,
No,
no. I think if any bear person can share on behalf of sir, that
no, it
may
is.
be helpful.
Yeah, I think. Sir,
No, some other desktop is sharing.
Yeah.
Is it coming now?
Yeah, it's
No, no.
uploading. Sir.
Coming?
It is loading, sir. It is loading. Hopefully, it will come.
Yeah, network issue.
Oh, maybe the network because it is running.
So, shall I, sir, share it from my end, behalf of you,
Are
sir?
you? Oh, see, coming? No. No, signal is there. Nice.
Sir, you can do one thing, sir. You can log out and log in again.
Or do you have this presentation? You can share on behalf of sir.
Yeah, I do have with me, but I think
Yeah,
sir
yeah, it's coming now.
is with the presentations also.
Coming now?
Yeah,
Yes,
yeah,
yes.
coming.
Okay.
You can make it full screen. Yeah.
It's coming?
No, no, it's freezed.
No, something wrong.
So, anybody from tech team, do you like? Can you just help regarding the issue? Hello, tech team. Yeah. Yes. Sir, I can see your screen now. So here you can just open your presentation, I think. Just open your presentation.
But it's not showing anything. No.
Yes, it's fine now, sir. Think it's in.
It's showing,
Yes.
showing,
Yes, yes.
Yeah.
It's visible now, sir.
but it is not moving.
Yes, yes.
Yeah, now
Now
it's
it's moving, sir. Now it's moving.
Oh, now moving. Okay.
Yeah.
So these are the study which are different duration. What they are telling, if you do very aggressive treatment in the first few years, the number of injection in the future it significantly reduced. Okay, so what what they're telling, so suppose first 3 years very significant number of injection, then year you may get less than 5 injection, and for fourth year you will get less than 4 injection. Okay, so summarizing this, so what they are concluded that this is the best line of treatment, and what they find out, if the vision is very less, in that case if you start the treatment with this molecule, the outcome is much better. Okay, so this is what they are telling. So all this study, what they are telling that is this is the most effective treatment. So there is some other study which are little less duration, but what they are what they are like telling. So this is you can see. Hello, can you see?
Yes, 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 sir. It's
Okay,
visible.
okay.
It's
No,
visible.
here something is going on. Okay, okay. So first, what they are telling. So so here they have given like first 5 injection. After that, they divide the group into 3 groups. So one group is that fixed dosing. So at regular interval or 2 months interval, they have given the injection, and another group treat like 5 dose, and after that, say around like treat and extend, and another is that from the very beginning they have done the PRN. So what they found out, the most effective treatment is first 5 loading dose along with the treat and extend, which with less number of injection. So this is like something different what we are getting. So treat and extend, less number of injection, but the visual outcome is much better. So this is one more study where they have given 5 monthly dosing, and after that they have seen up to 2 years. What they have and with every monthly follow-up, the maximum interval of the treatment is almost around almost 3 months. And what they get, say first year almost around 8 to 9 injection, and left second year almost around 3 to 4 injection. And with that, what they have got, so with like almost around 14 injection, what they are getting, that there is a improvement of the vision, and the vision also persisting at the end of 2 years. This is one more study where the same protocol, but the maximum interval what they have taken is almost around 16 weeks. That means almost around 4 months. And what they got here, the number of injection is 11.4 in comparison to the other 3 months interval, which is almost around 14 injection. So with 11 injection and with 2 years, they have got a very good visual outcome. And this is one more study where with one more one year, and they have got the similar outcome. So basically, what the study are telling, with initial maximum number of injection with 4 monthly injection, and after that treat and exchange is giving a beautiful result to maintain the vision. So this is for the outcome. I'm not going to all the detail. So what the summary is, yes, this is the best treatment for for the management of the diabetic macular edema. And so after that thing, so the most important thing, what is the safety? So this studies what are telling is this is the most safest injection among all the injection, which is only 0.6 cases out of, that means almost 6 cases in 1 lakh. Okay, which is very, very minimal. So this is safe, effective, and economical also. But the real problem is what? The practical problem. So what Dr. Sarangi has shown the clinical presentation, yes, that is most practical things, because these patients, particularly diabetic macular edema patients, they have multiple systemic problem. So it is not possible to fulfill these protocols for a long time. Okay, that is one thing. Second thing is that what we are telling, that like first you give 5 injection, after that like in the 5 years, I am sharing a very good response from my patient who knows what will happen after 5 years. So I will spend this much of in the initial phase. Okay, so these are the practical problem. Okay, and overall the cost, because in comparison to the biosimilar and other things, this is also a practical problem. So and this is about my presentation. Thank you.
Thank you for your short and crisp presentations, sir. My question to you is, as you are practicing in a premium hospital in Kolkata and your patient profile is also premium where budget is not that much constrained. So do you prefer to follow the protocol like load the patient with 3 or 4 injections and then to treat and extend or PRN or?
Yeah, that is a very good question. Okay, very good question. Okay, so basically, even if you have a premium patient and all these things, there are few constraints. Like most important thing is that, like, see the initial, the loading dose and all this, what is the 5 and all these things, most of the patient refuse to take. Okay, till now I was searching the my all patient profile. Till now I don't have a patient who has taken 5 loading dose and return extent. Okay, so up to 3, yes, but 5 is till now I don't have a single patient. Okay, and second thing is that, like, see, now we are the previous question what you have asked, like about the other molecule and all these things. Yes, definitely. The most important thing, the biomarker. I had a study with all the molecule patient with the biomarker. Okay, so definitely the newer molecule having the most effective reduction of the biomarker. Okay, so usually I start with little bit like higher molecule, and after that, like with see what is it? If you start with very high molecule, long term, yes, definitely the number of injection and all things significantly reduces.
So your theory of treating the patient is hit hard from the very beginning. And in continuation phase, do you prefer to switch to less potent molecule if the patient is not affording to the this high budget molecules, or do you prefer to continue the same molecule if the patient is responding well?
Yeah, that is also a nice practical question. Okay, so basically what I've seen, see, basically when we start with the higher molecule, what I'm seeing, the number of injection is gradually reducing. So usually patient affordability and all these things is usually practically is not a big problem. Okay, so that is one thing. Second thing is that whenever I feel that if it is not working, I usually switch up. Oh, so switch. Okay, so that also work nicely. Okay, so I'm sharing one patient like so I've given fast with Vabysmo, 3 injection. No, I have not got any such of effect. Okay, which is very unique. Okay, not in diabetic, but in some PCV. Okay, but I switched to Broly and it has worked wonderful. Okay, so then the patient was asking me. See, the practical question is there. The patient was asking me, "See, we have gone. We thought like this is much better. That's why we have started on all these things. Now you are telling that you have to change." Yes, I told yes because it is not working. And after one injection, when they saw the practically what is the reduction and all these things, they told, "Oh yes, this is wonderful." Okay, so probably convincing the patient like it's not like a very big thing.
And yes, yeah, and you have also highlighted the point that the safety profile of aflibercept is, I think, in my opinion, it is best among all the molecule. It is no doubt
Yeah.
about it is the safest molecule. And in my short clinical practice duration, I have not seen a single patient where there is a reaction after aflibercept injection. That and after the this news are coming in aflibercept biosimilar, some reactions or some challenges are there. So till now, aflibercept, even after the it has reduced its cost, so it is the best molecule, I think, safety wise and also efficacy wise. And this budget wise also, it is now affordable to the patient. So that discussion will going on because it is 10 o'clock. It is time for dinner. And thank you all the speakers for your insightful clinical experience. Like Dr. Shubhendu Bodal sir has emphasized about start with less potent molecule with gradually increase to more potent molecule. And Dr. Rachita has emphasized about observing the patient in chronic persistent DME with few cystic spaces rather than keep injecting and trying to dry the macula. And Dr. Yashaswal has also emphasized that he is preferred to start with higher molecules, and if possible, if the patient is stable or if patient has a need for other injection, he can switch to lower potent molecules to follow up the patient. So if there is any more question to the Bayer team, they can ask about, or we will wrap up the session.
Just one last question. I wanted to ask, has anybody used the biosimilar of aflibercept? Very recently, we have got reports of the side effect, but
No,
has anyone used?
I have not used. They have
I have used one,
Okay.
but recently, but my patient till now there is no complications.
Okay.
I can tell you that what is the efficacy because the patient has not come. I think last 2 weeks back I have started using.
Okay.
Okay.
So they will supply our institute some free samples. After that, we will use, and after that, we will can come to a conclusion.
Generally, with the new molecule, I'm always a little wary in starting off. I just wait till others experience. I have some at least good this one from others who are using it, and only then I start.
And after the cost has reduced to almost half in parent molecule, so why to switch to
Correct.
a less safe molecule with a
Correct.
just 5,000-6,000 less price?
Correct. Also waiting for the 8 mg.
Yeah.
Maybe that'll also increase our chances of, I mean, durability will increase with
Right.
that probably.
So can we wrap up,
Yeah.
Rishi?
Right.
Yes.
Yeah, I think, sir, we can wrap up. And before that, I would like to extend my gratitude and thank you so much, Shomavu sir and SS Pal sir, Madam, Rachita Madam, and Boral sir for the wonderful session and interactive sessions. And thank you so much, sir. Thank you for your all support. Right.
Okay. Good night. Good
Good
night.
night.
Thank you.
Good night.